And without further ado, I will hand you over to our chair for today, Angela Cunningham. Thanks, Angela.
Thank you very much. So good afternoon, everybody, and thank you for joining us in this, our next webinar in our safety culture series. And this one is around systems for learning. We're delighted that you could all take some time out of your busy days to join us. And as Damien has already said, this will be available as a recording for other clinical staff who couldn't make it today to join us. Next slide, please. So what I would like you to do is just to have a think about how you're feeling today and use the chat box to pop in an emoji just to give us an idea of how you're all feeling. So if you just take a second to do that quickly. While you're doing that, I'll just tell you that during the breakout sessions, there'll be about 4 or 5 of you in each session, and there will not be any recording of those sessions and they will not be facilitated. So that's a safe space just for you to chat for yourselves. So we've got some emojis all coming into the inbox there. Thank you all very much for that. Oh, they're all starting to pour in now. That's great. So if you just move on to the next slide, Elaine, and we will continue to put these emojis in. So what do we mean? What are the aims of this webinar? So really what we want to explore is what do you mean by a learning system in the context of improving quality and safety, which is what we're all about in the MCQIC programme. We want to look at the practical considerations for the establishment of an effective learning system and how this fits with the wider essentials of Safe Care resource. Evaluating today's webinar is obviously going to be very, very important to us, and we're actually doing a test of change as well that's been suggested by Damien. So we're going to ask you to scan the QR code that you'll see on your screen at the end of the session and for you to give us your feedback that way. Your feedback is essential so that we know that the webinars that we're doing actually meet the requirements of service and help them improve quality and safety for all our service users. So next slide, please. So this is our agenda for the afternoon. We've got a busy afternoon. We're going to hear about the essentials of safe care. We're going to hear about enabling learning system in the context of QI and the practical example of applying a learning system. Next slide, please. So I'm going to hand you over now to Jo Thompson, who's our Senior Improvement Advisor in Healthcare Improvement Scotland on the MCQIC programme. So
Thanks, Angela. Thank you. Good afternoon. My name is Jo Thompson. I'm a Senior Improvement Advisor leading the Maternity and Children Quality Improvement Collaborative. It's great that so many of you have joined us today, and I'm really looking forward to this webinar, to hearing from Michael and Emma, and to your questions for our speakers too. So please jot down anything you'd like to ask them. And as we've said, you'll have a chance towards the end of the session to put your questions to them. And thanks to Michael and Emma for taking the time to speak to us today too. Have the next slide, Elaine. So if you've managed to join us for our staff wellbeing webinar in February, the next few slides will be familiar to you, so apologies. But for those of you who couldn't join us in February, I wanted to take the opportunity to give you an overview of the Scottish Patient Safety Programme, SPSP, and how we're structuring our work now. So SPSP aims to improve the safety and reliability of care and to reduce harm. And there's 3 core elements of the SPSP. So the first is the essentials of safe care, which you'll hear more about in a moment. We've got our programme improvement work, and we've got our learning system. Have the next slide, Elaine. So the Essentials of Safe Care was published in March 2021, and it's a package of evidence-based guidance and support designed to be applicable across all health and care settings. And we'll pop a link to that in the chat box for you. It was developed with a range of stakeholders in response to requests from teams following the first wave of COVID. It includes an interactive driver diagram, a readiness and prioritisation tool. There's a measurement framework there too, and a toolkit to support teams who'd like to measure their progress, although it's not mandatory. And there's information there as well around our evaluation of the testing. And the package supports us in creating the conditions for the safe delivery of care. And the next slide, Elaine. So this is the essentials of safe care driver diagram. There's 4 primary drivers, which are person-centred systems and behaviours, safe communication, leadership to promote a culture of safety, and safe, consistent clinical and care processes. And you might be familiar with many of the concepts in the secondary drivers, and on our website, you'll find resources and tools to support each of these. Next slide, please. As a team, we've been having virtual visits with each of the NHS boards in Scotland. And a theme that's emerging from these conversations is a request for resources around supporting a safety culture. So we've designed this webinar series around the primary driver of leadership to promote a culture of safety. And we're running webinars on each of the secondary drivers. So that's staff wellbeing, learning systems, and psychological safety. Each has a keynote speaker and an example from an NHS board. So please join us if you can, or catch up on the recordings which are available on our website. This is the second webinar in this safety culture series. The first was held in February with a focus on staff wellbeing, and the recordings on our website now. We had 2 fantastic talks, one from Camilla Kingdon, the President of the Royal College of Paediatrics and Child Health, and the second from Emma Hepburn on the We Care programme in Grampian. Next slide, please. So the team running this webinar series are all part of the Maternity and Children Quality Improvement Collaborative, MCQIC. And MCQIC is part of the Scottish Patient Safety Programme in the iHub of Healthcare Improvement Scotland. And we support quality improvement through our 3 programmes, SPSP Maternity, SPSP Neonates, and SPSP Paediatrics. And we hope that the content of this webinar series is relevant to anyone with an interest in leadership to promote a culture of safety. While some of the examples we share might be focused on our clinical communities, the messages and learning and our keynote speakers are relevant to anybody. Next slide, please. So finally, from me, the third component of the Scottish Patient Safety Programme is our learning system, where we share learning and support networks, produce data and share evidence. And as an example, this webinar is one of those resources as part of our learning system. And it'll be available together with the slides and reading list after the session today. And our final webinar in this series is in April, and it has a focus on psychological safety. We're delighted that the internationally recognised patient safety expert Suzette Woodward will be our keynote speaker, and that colleagues from NHS Ayrshire and Arran will be sharing their staff culture survey work. So please sign up for that webinar if you've not already, and share that link with colleagues as well. The more the merrier. I'll hand back to you, Angela. Thanks.
That's lovely, Jo. Thank you very much for that. So this afternoon, we've got a busy afternoon and we've got 2 excellent speakers with us. So I'm delighted that they have both taken time out of their busy days to join us. And I'd like to introduce our first speaker, who's probably well known to a few of us on the call. This is Michael Canavan, and Michael is the Quality Management System Portfolio Lead within Healthcare Improvement Scotland. So over to you, Michael.
Thanks very much, Angela. Thank you. Good afternoon, everyone. As Angela says, my name is Michael Canavan. I'm currently the portfolio lead within the QMS portfolio within the iHub at Healthcare Improvement Scotland. And I was just reflecting there on Jo's announcement of the next speaker at the next session being an internationally recognised speaker. I think it's fair to say that I am certainly not an internationally recognised speaker on learning systems. And I think the reason that Jo asked me just to present today, and thanks very much for the invite to do so, Jo, is because of some work that we've done within the iHub around learning systems. We wanted to build on the learning system component of our quality management system framework, which I'll talk a bit more about just shortly. And we want to do that in response to an increase in appetite and need from the teams across the iHub supporting the system to develop learning systems. And I think it's really important, actually, that I acknowledge the work that's been done by the whole of the QMS portfolio team to pull together some materials around learning systems, and that's probably what I'm going to predominantly talk about over the next half hour or so. And if using the slide template that Joe and the team provided, I had to insert a picture. So I thought, since I was talking about learning systems, what better picture to use than this one here of me teaching my son Ryan many years ago how to play the guitar. He got a guitar for his Christmas, and here he is learning, I think it's the chord of V that I'm trying to show him. But as you can see from the picture, he's much more intent on smiling for the camera than he is about learning the actual chord that I'm trying to teach him. So enough about that. So as I say, I'm no expert in learning systems, but the learning system is a very important component of our quality management framework. And it was one of the most difficult concepts to describe and explain. So we took a bit of time to really think about, well, what do we mean by learning systems in the context of improving quality and safety? And we set about building some guidance for teams within the iHub and across health and social care to think about how they might practically apply and establish effective learning systems. So who am I? Well, I've already seen some chat coming in, some people saying we know you well, Michael, so I know that there are some familiar faces on the call, but my background is that I'm a registered nurse. And this is a picture of me. You can see there's a theme here, isn't there? I'm obviously harking back to my darker haired days, but this is a picture from probably the early 90s, actually, when I was a junior staff nurse and working in the medical intensive care unit in Falkirk Royal Infirmary. And working in the medical intensive care unit in Falkirk Royal really had a massive impact on me and my career and my development, mainly because of those two other nurses that you see in the picture, May and Charlie. So and the reason I sort of have this picture, and the reason I want to refer to my time in medical intensive care, is because without realising it, way back in the 1990s, Charlie and May were teaching me about quality improvement and teaching me about quality management, and really highlighting the importance of effective learning systems at a team level. So this was around the time of thrombolysis, when we used the clot busting drug for patients with heart attacks. And May and Charlie had taken time to read the literature, read the evidence, and had identified the kind of optimal sort of timelines for patients receiving their clot busting drug for heart attacks. And they also looked at the kind of data that we had within our team, and they quickly highlighted that we weren't even close to the optimal timeframes for thrombolysis. So Charlie and May were committed to improving that and really thinking about, well, what do we need to do differently in order to ensure that our patients get thrombolysis more quickly and therefore have improved outcomes. So if possible, if anything today, I hope to maybe demystify what we mean by learning systems by keeping it fairly practical. So that's a wee bit of my background. Registered nurse, moved on to resuscitation, and when I was a lead resuscitation officer, I had the opportunity to do the Scottish Improvement Leader Programme in cohort 1, and I would probably say that's probably been the most profound learning experience that I've ever had since graduating as a nurse, and really opened up lots of opportunities for learning, applying that new learning, and opportunities to go in and develop myself. So I worked for a while as quality improvement lead. After completing skill cohort 1, my boss decided that I should no longer be called the lead resuscitation officer, but in actual fact, I should change to quality improvement lead for resuscitation and deteriorating patient, which was a big shock, but allowed me to apply the new knowledge and skills that I'd got from skill cohort 1. Worked for a short time at NES as principal educator, teaching on skill mainly for the nursing cohorts. And then after a short time became portfolio lead for QMS at the iHub. So that's a wee potted background to my experience in history. And I thought since I am the the portfolio lead for quality management, I thought our quality management framework would be a good place to start. So you can see here the Healthcare Improvement Scotland quality management framework, and I'm just going to take the opportunity to post in the chat a wee link that you might want to use just to have a look at that if you want to know a bit more about our quality management system framework. I've posted that link in the chat. So as I say, as portfolio lead for QMS, I thought a good place would be to start with the framework, and you can see right at the centre of the framework is this idea of a learning system, right at the centre of what some of you will recognise as Duran's trilogy. But there are a number of components to the framework, some of which we could describe quite easily and others which we found quite difficult to explain. So we decided, let's take a bit more time to try and explain what we mean by learning systems, and as I say, give people some practical hints and tips to establishing effective learning systems. And whilst it might be tricky to describe and explain, I think it's fair to say that there's an awful lot of literature out there around learning systems, and I'm not going to be able to speak about it all, but I'm going to refer to a couple of important documents that have really helped us think about the guidance that we've produced. So the idea of learning systems was first conceptualised around 2007 in a workshop organised by the US Institute of Medicine. And at that time, they were kind of building on ideas around evidence-based medicine and practice-based evidence. And as you can see here from the quote in inverted commas, they're describing a learning system. Science, informatics, incentives and culture are aligned for continuous improvement and innovation, with best practices seamlessly embedded in the delivery process and new knowledge captured as an integral byproduct of the delivery experience. So that's a notion of using the evidence, but then applying that in practice and creating new knowledge from that sort of practice-based care. And I've popped the link on the slide there if you're interested in looking a bit more detail about that. Another piece of literature that I looked at and that I found really helpful actually was this model by Charles Friedman and Macy. And I found this really quite straightforward. So this sort of model describes that time where you take a decision to look into something in a bit more detail, to understand it better, to study it. So what they say is you need to gather and assemble the relevant information, the relevant evidence, the relevant data, and take time to analyse that. And once you've done that, then thinking, well, how do we interpret that for our own practice? Thinking carefully about how you deliver that message, how you communicate that, and then take action to change practice. And as you'll see in the guidance that we've developed, that I think Damien has posted in the chat as well, you'll see that our learning system visual and materials are kind of based around this idea. A couple of other documents that are worth probably looking at is the IHI framework for safe, reliable and effective care. And if we're talking about learning systems for quality and safety, this is quite a good document to look at. And you can see quite clearly here that they're highlighting the importance of culture and the importance of learning systems. And this framework was designed to provide clarity and direction to healthcare organisations on the sort of key strategic, clinical and operational components involved in achieving safe and reliable care. So they describe it as a system of safety and trying to move away from that, just a collection of standalone safety improvement projects. So again, the link's there for you to look at if you think that would be useful. And just finally, before I go on and talk about the work that we've done, I didn't want to talk about learning systems without referring to the work by Toby Lowe around human learning systems. And this work draws on and brings together the practice, ideas, insights, contribution of a variety of people and organisations to address change in complex systems. And as we know, in health and social care, it is very much a complex system. So working alongside public and voluntary sector organisations, this is about developing an alternative approach for public management. and they describe it as one which enables public service to work more effectively in complex dynamic environments. And actually only recently I realised, you'll see here that each word is followed by a full stop. And when I was first introduced to the human learning system concept, I completely missed that. I didn't realise the very specific nature of each aspect. So for the human aspect, what they're talking about here is focusing the attention. So we as healthcare practitioners, professionals, should be focusing on building relationships with the people that we're here to serve, to understand their strengths, their needs, and respond appropriately to whatever those are. And in terms of learning, they're quite clear that in situations of uncertainty, we often don't know what the right thing to do is. There's no manual to operate from. So we need to learn as we go. And I think the last 2 years of dealing with the COVID pandemic has really, I think, highlighted that, hasn't it? That idea that at times we haven't had the answer and we've had to learn as we go. And I'll maybe talk a wee bit more about that just in a wee while. But they also highlight that it's the job of managers to create emergent learning environments and practices. So we should be thinking carefully about that. And in terms of systems, they highlight the notion that healthy systems are ones in which different sort of participants are able to coordinate and collaborate effectively. So healthy systems produce good outcomes, and they're characterised by trust, openness, and honesty. And again, thinking about healthy systems, they're quite keen to highlight the role of leaders at all levels to create and nurture healthy systems. So just a few important articles that you might find useful. It's not an exhaustive list, and I know that the team have put together a reading list around learning systems, which we will share along with these resources. But I just felt that it might be good to just use that as our foundation for the work that we did. And I also thought, well, thinking about all of that, what's my experience in learning systems? And I talked earlier on about my time in medical intensive care and the importance of learning about early thrombolysis. And I was also reflecting on the time when I was a resuscitation officer, and I was part of a really strong group of resuscitation officers from across Scotland. And again, without realising it, I remember sitting in a lecture theatre with all of my Scottish resuscitation officer colleagues, taking time to interpret the new European Resuscitation Council guidelines. So taking time to sort of make sense of them, look at the literature, look at the evidence, start to make sense of that and think, what does that mean for us in terms of practical application of resuscitation? And I think we were the first sort of country to develop a standardised approach to the application of those resuscitation guidelines through coming together to learn, create insights and think carefully about how we might teach those. So in actual fact, over a long period of time, regardless of where you've learned about advanced life support in Scotland, you will be taught the exact same approach to applying those guidelines in the clinical setting. So we didn't call it a learning system, but we took time to look at the evidence. We took time to think about what that meant for us, and then time to think about, well, what do we need to do about that then? And then I was also thinking about the time as a quality improvement lead, some of the other learning systems that I've been involved in. Some of those will be very familiar to you. So just to give you a wee pause, a wee break from my voice, I'm going to invite you to take the opportunity to think about examples of learning systems that you've been involved in and just share those in the chat box. And if nothing else comes out of this, you might be able to make some new connections with people that are working on stuff that you're interested in. So what learning systems have you been involved in? Pop it into the chat box. I'm hoping at least some of you are typing.
I think they're all a bit shy, Michael. I'm not seeing it much coming in.
I'm just watching for that, yeah. Oh, here we go.
Yep.
Emma says the Knowledge Hub. Great stuff, thank you, Emma. I'll give you a wee bit of time just to sort of think about what you're doing and pop it into chat if you like. Asking patients what we're doing well and what we could improve on to improve their care experience. Love that idea, Laura. Love and you know, I think as part of our quality management system framework, we highlight the importance of co-design, co-production and building those relationships. So I think there's a much bigger effort to really ensure that we are building in patient experience. Great stuff. So I see a few more coming in now. Excellent. Joe says, sharing learning with other senior improvement advisors and teams in SPSP across the iHub and HIS. Brilliant. And I'll probably come on and talk a wee bit about that later on, Joe. So I'll move on to the next slide, if that's okay. So whilst also thinking about my experience, I mentioned earlier on the past 2 years where we've had to learn as we go, and I was kind of thinking about some emerging examples of learning systems in response to COVID. And again, this is by no means an exhaustive list, but a couple that really piqued my interest. So the first one there, ICM Anesthesia COVID-19.org. This is a website that emerged in response to need for clinical information about how best to manage patients in intensive care with COVID. And in actual fact, it's 4 organisations working in collaboration. So it's the Faculty of Intensive Care Medicine, the Intensive Care Society, the Association of Anaesthetists and the Royal College of Anaesthetists collaborated to provide information, guidance and resources for better understanding and management of COVID. And I know a few of my anaesthetic colleagues that I've worked with over the years found that extremely valuable throughout these past 2 years. I was speaking to a colleague recently who works in anaesthetics, and he was saying that he actually is part of a WhatsApp group that involves clinicians from the UK, from all across Scotland, the UK and America, and they found that extremely useful in terms of new information, new evidence, new guidance, and just sharing of learning. The other one that I've listed there is the NHS Nightingale Hospital in England at the beginning of COVID, where the leadership team proactively decided that they would apply a learning system model quickly to create and refine the care delivery system within ICU. And in actual fact, they highlight that they believe that you can use this learning system approach in normal everyday care settings with familiar diseases, and they found that extremely helpful at the beginning of COVID. And then I've left the final example there is just one unit within the iHub who developed a learning system as a way to understand how health and social care across Scotland was responding to COVID, and to think and identify key learning for the future. So a couple of examples that might be useful to you. You could probably think of many more, but certainly I found those extremely useful when thinking about the guidance we can provide for people and teams thinking about developing and establishing their own learning systems. So Joe has already talked about this, but when I was thinking and preparing for the presentation, I just wanted to know a wee bit more about the sort of change theory around essentials of care. And Joe's already highlighted that system for learning secondary driver related to leadership to promote a culture of safety at all levels. And delving a bit more deeply into that, we're starting already to identify change ideas. And so again, just referring back to the QMS framework, learning system right at the beginning, but very difficult to describe and explain. So we want to take some time to understand that better. In actual fact, here's our very first iteration of guidance around learning systems, and you'll see some of the stuff that Joe highlighted in the change ideas has been taken from that initial thinking. So, like I said earlier, difficult to explain, difficult to describe, and certainly I think needed a bit more thinking because we just didn't feel as able to describe it as well as we would quality improvement, quality control, co-production. So because many teams were identifying the need for learning systems, we set out to define it and think about the core components. So we've done that. We've spent a bit of time thinking, right, what do we mean by learning systems and what do we think are the essential components? And what I'm presenting here is a really high level visual of the practical steps that any team can take when they're thinking about developing and establishing a learning system. And This is backed up with some web pages. As I say, Damien has already posted the link to our web pages around learning systems. And I'm going to make a wee appeal at this point in time. If you get the opportunity to look at our learning system web pages, there's a facility within there for you to provide us with some feedback. And, you know, we're not confident that we've got everything right. We've tried hard to provide helpful guidance. We don't think it's a fait accompli, you know, we don't think it's a finished product. We think we can continue to improve it. So we'd love to hear your feedback. What's helpful for you? What are you finding useful? But more importantly, what do you think would make it even better? So please feel free to provide us with some feedback on the learning system web pages. But I'm just going to now delve into each of those components in a wee bit more detail. So we've come up with a definition. So what's a learning system? A learning system enables a group of people to come together to share and learn about a particular topic, to build knowledge and accelerate improvement and outcomes. We're really keen that it should be about accelerating improvement. So thinking about learning for spread, learning for scale up, learning for really helping to impact across the system. And some key things that a learning system should do or be, so it should support individuals to learn through its culture and network. So creating that culture where you have the time to reflect and share in a safe space. I'll talk a wee bit more about networks just shortly, but we feel quite strongly that if you're going to create a learning system, you need to think about who needs to be part of that. It should be informed by evaluation and reflective practice. And I don't know if you noticed on that last slide that I showed, we had an evaluation box at the bottom that went from one side to the other. The idea being that we're recommending that if you're going to embark on a learning system, you think about evaluation from the outset and don't wait until the end. So think about how you can evaluate the impact of your learning system right from the very beginning. It should enable us to assess what is and isn't working through data, stories, insights, and it should help us to develop processes to aid decision making and turn that knowledge into action for improvement or redesign. And it should help us to build systems that enable us to identify those bright spots or generalizable learning and think about how then we spread and scale that quickly. You know, I think at this moment in time, we're probably under enormous pressure to take good evidence, good practice, and scale it up and spread that up to more and more patients so that there's more and more equality. So one of the first things we talk about is establishing your learning system, and any learning system will only be as good as the processes and infrastructure supporting it. So taking the time to think about what you need to do in terms of planning, resources, and business infrastructure, and then thinking about how you can support the scope of the learning system and how you might evaluate it. So the three key questions that we encourage people to think about right from the beginning is, what's the learning system's purpose? And in actual fact, through a number of conversations that we've had recently, and Jo mentioned in the chat that she's taken opportunities to share learning with colleagues in SPSP and colleagues across the iHub and colleagues across HIS. So we're already identifying very neat, refined learning systems. So it could be around an aspect of safe care around pressure ulcers. But then some people are also talking about, well, you could have a focus on an improvement programme around mental health. And if there are a number of programmes focused around mental health, how then do you create an overarching learning system? So it starts to get a bit complex, but right from the outset, thinking and taking time to be really clear about the purpose. Who needs to be involved and how? And I know that in my past experience, I've often thought, right, we've got everybody we need in the room, and other people say, you haven't thought about this person, you haven't thought about that person. So really canvass opinion, ensure that you've got the right people. And I think COVID has really highlighted and brought into sort of start focus the issues around inequality. So again, if we're looking to learn to improve and learn around safety, we should probably also be thinking at the outset about the importance of inequalities. So do we know about any issues related to inequalities, and can we think about how we build that into our learning to try and reduce inequalities? I I've talked already about supporting, and I've talked a wee bit about evaluating. So trying to think about how you can evaluate from the outset, collecting evidence of impact, sharing findings, experience, and again, how you can evidence how you're improving those inequalities. And then in terms of the core components, what I didn't highlight, in fact, I'm just going to quickly go back actually, because I didn't mention it when I was talking about it. So let me just quickly go back to an earlier slide, this one here. What I didn't highlight was this Celtic knot in pink here. So these are the sort of doing aspects of the learning system. So gathering insights, making sense of those insights, and then thinking about how you turn that into action through the network of people that you've gathered together. And we put this into a Celtic knot to sort of portray that idea that it's not a linear process. And I know in my experience in the past that quite often I've thought, right, I've gathered my information, now I need to do such and such, and I go to do such and such and realised, oh, hang on a minute, I don't know enough about A, B or C. So the Celtic knot's there to describe that sort of dynamic process of gathering information, making sense, knowledge into action through the network of people that you're working with. So just to talk a bit more about those, you can see here, in terms of gathering insights, that can be done a whole variety of ways. I'm not going to go through each bullet point there, but there's the evidence, there's the practical experience, there's making sure that there's an opportunity to learn from others through formal and informal conversations. And I mentioned earlier on that culture where people have time to notice, reflect, and share information. And then using all of that insight evidence to then make sense of that for the variety of contexts that we're all working in, and to connect to local priorities, national priorities, and what's going on within our system. And as I say, in terms of sense making, taking the time to look at the data, to understand the variation, and thinking about the culture and behavioural conditions. So just some bullet points that I'm drawing on there. And having gathered those insights and made sense of them and gotten to a stage where you think, now we can do something differently. We can turn that knowledge into action to improve services or create safer services. But that requires a bit of time to think about enablers and barriers, thinking about, somebody mentioned earlier on, the importance of co-design and co-production. So working with the people who use our services and the people who deliver the service to co-produce the tools and resources. But as I said, none of that can happen without the network of people who come together to create those relationships and build that community who are committed to sharing and learning together. And again, just in the interest of time, I won't refer to every bullet point, but I think the key thing here is, in any learning system, it's important that we've taken time to consider who needs to be part of this and how do we make sure that we get them all together to share and learn together. So as I say, that's the high level visual, all supported by additional information, additional detail in our learning system web pages. And as I say, I would invite you all to take an opportunity to look at that, and we would love to hear your feedback once you've had the chance to look. So after having produced this guidance, and in response to a whole variety of teams identifying the need for learning systems, what we are now doing is thinking about how we can create, wait for it, a learning system for learning systems. So all of the teams across the iHub and across Healthcare Improvement Scotland are on a daily basis supporting teams out there across health and social care. And whilst we try really, really hard to do that in a collegiate way, sometimes it might come across to the system that we're not working in a collegiate way and we're all doing our own thing. And I think, as Joe mentioned right at the beginning, this session today is presented by MCQIC, but it's relevant across the whole system. So we're trying to think about how we can join that all up. And what we've started to gather is some information about the variety of learning systems that we have within the iHub and who the audience might be. And what we then need to do is to gather insights and make sense of that and think, how do we minimize duplication? How do we present what we're doing to the system in a way that's helpful to the system? And we recognise we need to get better at that. So that's just a few examples of the learning systems that have developed within the iHub. And I think clearly there's the opportunity for a more joined up collegiate approach. What we've also done as part of that insight gathering is started to think about, well, what are you finding are the enablers? So I thought it might be worthwhile sharing that. So if you are thinking about setting up a local learning system, then here's some insights from the teams within the iHub who've created their own learning system and to help you think about, well, what might enable it. So leadership, I've already highlighted, really important, really crucial. Regular communication in a variety of ways. Webinars led by those delivering the work locally, so hearing from the people who are actually delivering it. Flexibility, I think we're all working in probably increasingly busy, increasingly pressurised roles where we find it difficult to take time away from our everyday work to take part in things like this today. So Joe and the team are recording it so that it's available to people at a time that's more convenient to them. So how can we create flexible ways for people to learn together? Again, just in the interest of time, I won't go through every bullet point, but just some ideas to think about that might enable you to develop and establish a really good, effective learning system. Some of the teams have also shared some of their successes. So the teams are highlighting through the feedback is the importance of peer-to-peer support and relationships. And not only is it helping teams and individuals to learn more, but they're building up that network of support and improved relationships. And one team in particular highlighted that they had set up an MS Teams channel as part of their learning system and had noticed that not an awful lot was happening on the MS Teams channel. And I would probably, that kind of resonates with me because I know that I'm part of quite a number of MS Teams channels and it's difficult to keep up with all of them. But what they also, when they looked into that and explored it, what they found was that a high rate of people were connecting offline. So they were taking the time to speak to each other away from the webinars and away from MS Teams. So if you have got an MS Teams channel and you're thinking, oh, there's not an awful lot happening, it might be happening offline. One team in particular, our MCQIC team, through the learning system have generated a change package, which has now been used within the system. And one team spoke of the benefit of initially focusing on the senior leadership team to really understand their aims and their value and purpose before thinking about the purpose of the learning system. And one other thing that has been mentioned is the importance of data for impact, again highlighting that need for ongoing evaluation. So that's pretty much all I have to say on learning systems, and I hope that what I've been able to do is maybe demystify some of that and give you some hints and tips if you're thinking about developing your own learning system. So thank you very much for listening, and I hope it's been useful.
Michael, thank you very much for that. I don't know about anybody else on the call, but I think you've given us a vast amount of information. I'm sure lots of us are thinking about it and wondering how we'll be using it in our system. I know everybody on the call today doesn't work with the MCQIC team, but I know within the MCQIC team, we'll be looking at how we utilise that moving forward as we start working with the boards and taking on new pieces of work. So thank you very much. And I would recommend that everybody goes to the link that's been posted to read up more about it. So Michael has very much given us a huge amount of information around a system for learning. So how does that work in practice? So I'm going to go now to Emma Campbell. Emma is a senior charge midwife in NHS Lothian. And Emma is going to tell us about applying a learning system approach to the PMRT process. So that's for those who don't work with the MCQIC team and in maternity services, that's the perinatal mortality review tool. So I'm going to hand over to you, Emma, And thank you very much.
That's lovely. Thanks very much, Angela. So I'm happy to be here today, and thanks to Damien and the team for inviting me along to give a presentation. So as Angela said, my name is Emma Campbell and I am a senior charge midwife in NHS Lothian. My background is the antenatal postnatal ward, and I've had a lead role in bereavement for the last 8 to 10 years within NHS Lothian as well. I'm currently on secondment to the risk management team within Women's and Children's Services, and that's where I started this project with the shared learning. Next slide, please. So just a little bit of background for NHS Lothian for those of you that don't know, although I'm sure most of you do. We work across 2 sites in NHS Lothian, one being the Royal Infirmary in Edinburgh and the other being St John's Hospital in Livingston. We also now have the Royal Hospital for Children and Young People, which is on the same site as the Royal Infirmary, which is really good for team working. On average, in a year, we will deliver 9,000 babies. And in terms of what that means for our PMRTs or our perinatal mortality reviews, a brief example for 2021 is that we reported 42 stillbirths within our health board and 36 neonatal deaths. So that's a total of 78. What that means for our team is we've currently completed 32 of those PMRT reviews. 20 cases within that number didn't actually require a full review, and generally that's because they fall below the gestational age that PMRT requires a full review to take place. And then 26 of the reviews are currently either scheduled or in progress. In progress means more often than not for us, unfortunately within Lothian, we've had a bit of a delay in process with our postmortems due to staffing, and for all of the postmortems within NHS Lothian, we have a 6-month wait currently for a full postmortem report to be fed back to our team and the families, although we are hopeful that we've had recent staffing increases, so we're hopeful that that's going to change in the not too distant future. Next slide, please. So a little bit of background about where we've come from in terms of PMRT. So we commenced the PMRT process within NHS Lothian in 2019, and that commenced with 2 non-clinical administrative risk coordinators and part of the team. They also work alongside what we call our commissioning team, and that is made up of 3 obstetric consultants, 2 neonatologists, and we have our clinical director and our chief midwife then and now as the director of midwifery. How that's changed is we now obviously have myself as a clinical lead role for the risk management team. The commissioning team at the moment is the same structure, but we are also now feeding into our senior management team, and they are all part of that commissioning group as and when they're able to attend. Other things that have changed, we have introduced the CDR process to our team, so child death review process for those of you that don't know. That's something that went live in Scotland on the 1st of October in 2021, but we started that process probably in January 2021. We chose to do some historical reviews just to try and get to grips with how that process was going to work within our service. It's quite a big undertaking because that means that we are doing all the reviews for all the child deaths now from the age of 2 up to 18, and then from 18 to 26 if they're in looked after or through care. And that's as well as what we currently do in our team with all our PMRT work and our significant adverse events as well. Other changes within the team, we now have a QI team that we work alongside. There are 2 people in that team at the moment, but others that are doing various projects. Working with the QI team, they basically have really helped us to look at our processes and analyse our systems just to improve the quality and safety and find good ways to share our learning and be a bit more transparent about the process and the outcomes that we get from all of our reviews. We also have somebody working with us now who does the EC4H training. For those of you that don't know, that's effective communication for healthcare. And that's bespoke training for healthcare individuals so that they can basically have some information and guidance on how to have difficult conversations within their role in healthcare. So what should we be saying and how should we be saying it? And we have adapted that training within our PMRT service, and we've made a bespoke training system for who we identify as key contacts for our bereaved families. And we're currently looking at another bespoke training for our medical secretary staff as well, because they obviously are also having some difficult conversations with families. Next slide, please. So this is just a very brief run through of what our current PMRT process looks like. On the right hand side in the picture, that is our process map, which is in the process of being edited and updated at the moment because it has changed a little bit. But to talk you through it briefly, notification of adverse events happens to us through our DATEX adverse event reporting tool, but we also have systems set up within our track electronic record. We don't use Badger, unfortunately, whereby this team will always get notification within 24 to 48 hours of all adverse events within women's, children's, neonatal services. And that's where we would pick up all of our stillbirth and neonatal deaths specifically for PMRT. Once we've picked them up as a team, we will start to make a brief summary or outline of the care and the case of that patient, and we fill that in on a reference and commissioning document, which we then take to our commissioning group within that same week. So all of our adverse events and PMRTs are commissioned within 1 week of the event happening, generally speaking. The commissioning process is basically just to do almost a quick look to see if there are any immediate safety concerns that we need to address, and if that needs to happen, then we'll take that forward as a team. Once we've done that, we then move on to notification of the key individuals involved in the care, so that would be community midwives, GPs and consultant obstetricians or any other healthcare providers that are important to that patient in our journey. And then obviously notification to the family as well. So we send them written notification about the review process, we introduce our team, and we give them information about follow-up that they will have with us and throughout the review and with their key professionals such as their key contact and their consultant obstetrician. We also at this point would refer any staff who have had involvement in this adverse event or PMRT, so stillbirth or neonatal death, to our structured peer support service, just in case staff felt like they needed to reach out for a little bit of support. We then will use our Being Open project and keep in touch with the families throughout the review process and make sure that they're aware that their thoughts and their questions are really important to us, and we encourage the key contact to keep giving that message to families and seeking their questions until we know the review is going to take place, because we always want to try and have a little bit of their input at that actual review. The review itself, we as a team will prepare pretty much everything for that. We complete a lot of the PMRT tool before we get there with information we have from track, and then as a team in that meeting, we go through every point on the forum and we will discuss the care, and hopefully that's when we then get to the point of agreeing the care and service delivery issues, any contributory factors and any actions that need to be taken forward or recommendations. And then it moves on into the approval process and sign off. Next slide, please. So this is the part where we've started to make things a little bit different in terms of how we share our learning and how we ensure that we're sharing quality learning with our service. So the first and most important thing is, once these reviews are concluded, there are a group of important people that have been directly involved in these cases that need to know what learning we've managed to come together at the end of the review. So we share it immediately with the lead professionals. So that's the team that actually completed the review and the other lead professionals that we've already notified. That does include service leads and our clinical management team. And then obviously the key contact. The report itself is then sent out to the family, and they obviously have an opportunity to read that and then come in and have a face-to-face meeting. After that, we then think of how we can share the greater points of the actual learning. Safety brief is a great tool. We use it very well within women's and children's services, but if we're going to use a safety brief, we need to ensure that it's a short, sharp and easy to say point of learning and action across the service. We don't want it to be too lengthy and complicated, because we know that that's when people can lose interest. And then our newsletter, which I'm going to come to on the next slide, and obviously everything has to go through clinical governance, because if there are actions that require service involvement or further management, then that has to have their approval and they have to decide who's going to actually take that on board. And data sharing is something that the QI team is also helping us get to grips with, so we're a bit more transparent about our learning within this system. Next slide. So this is our current model for our newsletter. I've only put the second page because the first page I thought was maybe a bit too wordy for this presentation. Basically what this looks like is we will always try and have a spotlight or a focus for every letter. And at the moment we're planning to do this every 2 to 3 months, but it might be something that we'll do monthly. So for this letter, we could easily see that from our reviews of both moderate major harm and perinatal mortality reviews for stillbirths and neonatal deaths, there's been a bit of a disconnect with our new Smallford gestational age pathway. It's quite a long guideline. It has a lot of risk assessment tools within it, and they are all very new to all of our clinicians, whether they be medical or midwifery. And we found throughout the reviews that if people understood it a little bit better, that then perhaps certain aspects of adverse events and adverse outcomes wouldn't occur or would perhaps be better managed along the journey. So that's why we chose that to focus on. And then in the other column, we've specifically picked out other aspects of learning that we felt were really important to share, but also have quite clear and concise actions that we think that our midwives and doctors will really like to hear about. As part of this, we want to encourage them to feed back to us as well if there's something they don't understand, if there's something that they want to offer help with or that they've got a keen interest in, then we would absolutely accept that. And I think what's been really well received by people is the little emoji man at the bottom where it's knowledge plus action is power. And I think people feel really happy that they're getting some feedback from our team now, because before I think they felt it was quite a closed process, and although they made a lot of reports of adverse events and are involved in them themselves, they felt like they weren't getting enough feedback about how we learned from it and how we were going to share that and make changes in our service. Next slide, please. And just next steps for us as a team, obviously we've got a lot of work to do, we always do, and we're very keen to take all of that on board. Review format is something we're currently looking at. So we currently share the PMRT tool as it is when we download it from the system with our families. We're very aware that that can be quite harsh for them to read. So we're looking at how we develop a more patient-friendly approach to that. We're evaluating our safety brief process because as much as we use it very well, we're aware that every clinical area does slightly different things with it. So we want to just make sure that we're still using that to the best of its ability within our service. And we're also have an evolving aspect of our bereavement care approach because we're an early adopter board to the national bereavement care pathways. So that is really in line with our service as well. So we're all working together to make sure that we've got a combined approach to that as well. Thank you very much.
Emma, thank you very much for that. I think it is really important for us to see how it is actually working in action out there. I think sometimes we read things and we think, how are we going to manage that? So that is fantastic. Thank you very much. So you're all now going to be, just go on to the next slide, please, Elaine. You're now going to go into breakout parallel sessions. As I've said already, there'll be about 4 or 5 of you per session. We're only going to have this for 10 minutes. So what we suggest is that as you speak, you introduce yourself, your reflections on what you've heard so far. These, as I've already said, won't be recorded. So this is a safe space for you to have a chat in. Take the opportunity to share your experiences, what examples of learning systems you're involved in, what would you share with others in terms of successful approaches to a learning system, what are the barriers and enablers to effective learning system, and please consider any questions that you're going to have for our Q&A session at the end, which will last for about 20 minutes. So there'll be a small hiatus while we're transported. And if you are ready to go to the breakout sessions now, that would be great. If you find yourself in a breakout session with nobody, because some of our colleagues have had to leave, could you just go into the chat box and say, and one of the admin team will facilitate you moving to another breakout room. Okay, speak to you all soon.